So good morning, good afternoon, good evening, everyone, and welcome to our session today. Our session is made possible given the funding support from the Gates Foundation. My name is Francis Ochen from the African Society for Laboratory Medicine. I am the moderator for this session, and I'll be supported closely by my colleague, Lucy. Before we start, kindly be reminded to take note of our housekeeping guidance. The session will be recorded and we will be running for an hour. We'll take 2 presentations and wind up with a Q&A. Kindly join the discussions through the chat space. And it's the Q&A space. That's the only possibility that you have to join the discussion. So get us your comments, questions coming through the Q&A space. We have simultaneous language interpretation services from English to French and Portuguese. So please navigate the icons in your device and select your preferred language. The session slides and recordings will be shared through our multiple social media platforms, and also it will become available on our ASLM resource page. You'll receive an email for those that require certificates, and guidance will also be provided there for you to pick your certificate of attendance. Today, colleagues, we look at hepatitis. And in Africa, we know that the burden, especially of hepatitis B and C, is huge, with millions living with these infections and many of whom remain undiagnosed and subsequently untreated. So our session today, which really aligns with the commemoration of the World Hepatitis Day, and we know that the World Hepatitis Day is commemorated on the 28th of July, and that will be next Thursday. So the theme for this year's Hepatitis Day is Hepatitis, Let's Break It Down. And so this theme calls for urgent actions to dismantle the financial, social, and systemic barriers that hinder elimination of hepatitis and the prevention of subsequent liver cancer that is associated with hepatitis infection. The campaign emphasizes the need to simplify, scale up, and integrate essential hepatitis services into the national health system. And so in this session, we look at some of the strides being made to enhance hepatitis prevention, diagnosis, and treatment through sharing some of the guidance on hepatitis elimination strategies, but also going with specific experience sharing from Uganda. And to take us through this, we have 2 distinguished speakers. The first is going to be Cary James, and Cary James is the Chief Executive Officer with World Hepatitis Alliance. And then our second and not the least speaker is going to be Dr. Linda Nabitaka, and Linda is the Senior Program Officer for PMTCT at the Ministry of Health in Uganda. So colleagues, let's hand it over to Cary James and then subsequently Linda, and then we'll get back with the question and answers. Cary, over to you.
Thank you so much. It's such a pleasure to be here today. So thank you so much for the invitation. Let me just get my slides up. So yes, as was already said, World Hepatitis Day is just around the corner. So I'd just like to take you through a few initiatives and what the World Hepatitis Alliance is doing to try to address really the hepatitis emergency that we're experiencing globally, but which is felt most acutely in Africa. In case you're not familiar with the Alliance, we're a network, an international network of civil society and community-based organizations in over 100 countries, all harnessing the power of lived experience and of communities to drive toward hepatitis elimination. So we do lots of shaping around policy on a global level, around guidelines, making sure that the voice of communities is heard in those processes. Our members do community-based testing, they do awareness raising and demand generation for PMTCT services. And we also run a lot of the hepatitis campaigns that you'll probably be familiar with, including World Hepatitis Day that we do in close collaboration with WHO, and also World Hepatitis Testing Week, which I'll talk about in a moment. because hepatitis is not not just a global health concern, but it's really an emergency because we have almost 300 million people living with either hepatitis B or C in the world. And the rates of mortality are increasing and increased from 1.1 million to 2019 to 1.3 million in 2022. And this is actually the highest mortality rate of any communicable disease. So it's really with mortality rates decreasing in HIV and malaria and TB and a lot of the big headline diseases that you see, you can see hepatitis unfortunately is going the wrong direction, is going the wrong way, really because of a lack of attention from global donors, a lack of prioritization in many countries, and that's something that we really need to address. We really need to address as soon as possible. And we know the majority of people living with hepatitis are undiagnosed. Only 13% of people living with hepatitis B globally are diagnosed, and only about a third of people living with hepatitis C globally are diagnosed. But in Africa, those numbers are even more acute. Only 4.2% of people living with hepatitis B in Africa have been diagnosed. And of those people, only 0.2% have been treated. So you can see we barely even started screening and treating people in the African region. And 63% of the new cases of hepatitis B each in 2022 were in Africa. 13% of people living with hepatitis C, only 13% of people living with hepatitis C have been diagnosed in the Afro region. And that's just a third of the global figure. And 25% of hepatitis B related deaths and 16% of hepatitis C related deaths are in the Afro region. So you can see that we really need more action in Africa to address this and to really get these rates up to where they need to be for such a large scale problem. So at World Hepatitis Alliance, we're addressing the need to increase diagnosis in many ways globally and within Africa. So I'm just going to talk about some of the strategies that we're currently pursuing in order to increase diagnosis rates. One is looking at the connection between liver cancer and hepatitis, because I'm sure all of you know that hepatitis is the leading cause of liver cancer, but this is very rarely recognized within health systems. It's very rarely included within cancer strategies. And really, in the absence of a large vertical program for hepatitis, which really won't be the most efficient way to address it, integrating into cancer services will not only benefit hepatitis elimination, but it will also decrease mortality from cancer. It'll be cost saving for health systems. So this is a big area of focus for us, and especially this year, since the United Nations is holding a high-level meeting on NCDs in New York in September. And as part of that, there's a political declaration that really outlines what countries should be doing in order to address NCDs. So it's a very important year, and it's very important for us to ensure that hepatitis testing is included within the political declaration, as well as treatment and vaccination. So we're currently negotiating with countries and doing a lot of advocacy behind the scenes to make sure that hepatitis testing, treatment, and vaccination for hepatitis B are all included in that declaration. But we're also engaging on a regional level. The Aortic Cancer Congress that happens every 2 years in Africa. We held our first session there in the previous meeting. It was the first time that hepatitis was represented at the meeting, and we had a joint session with the Union for International Cancer Control about this important thing. So I think it's really becoming part of the agenda within the cancer community. It's definitely part of the agenda for a hepatitis community, and we feel that this is one of the quickest ways that we can scale up hepatitis screening and treatment. We're also looking at the integration of especially hepatitis C screening and treatment with harm reduction services. Obviously, a very big stakeholder group for hepatitis C globally is people who use drugs. So making sure that where there are harm reduction services for people who use drugs, that hepatitis screening and treatment are part of the services that they provide, but also looking at mental health services, because around the world, the rates of hepatitis C amongst admissions to psychiatric units or inpatient mental health services are much, much higher than the general admission rate to hospital. So it is a great, can be a very effective way to find people who are living with hepatitis C, to test them and to treat them if necessary. And we're also from a community level, our community impact program is an e-learning platform which deals a lot with community-based testing, scale up of testing, harm reduction services. It's a really great resource, not just for community members, but for anyone who wants to learn more about a public health approach to hepatitis elimination. Of course, prevention of mother-to-child transmission, which we'll hear a little bit more about later, and triple elimination, which is a global strategy to eliminate mother-to-child transmission of HIV, syphilis, and now hepatitis B, are a big focus. And in Uganda, right at this very moment, there's the government of Uganda is co-hosting the Triple Elimination Conference, really looking at this strategy. And it's a strategy that's been adopted by UNICEF. I was at the International AIDS Society conference last week. It was a big talking point there. So this is really important that we screen all women in antenatal care for HIV, hepatitis B, and syphilis. And that if they do test positive for hepatitis B, that the woman is given prophylactic treatment, and very importantly, that the baby is given the birth dose vaccine within 24 hours. There's been additional support for this work from some of the donor organizations. Global Fund now has a provision for triple elimination within their work plans. And Gavi, the vaccine partnership, has begun their birth dose program. And I think there's 12 countries in Africa who have already applied to receive Gavi support to support the rollout of birth dose. So this is a really big area of focus, and a really effective way that we can use existing infrastructure around HIV, PMTCT services, and antenatal care in order to scale up hepatitis B elimination and stop the onward transmission. And one of the big things that we're involved in around this is the Safe Start Plus program, which is a multi-country program looking at implementing triple elimination and mobilizing communities, generating demand within communities for those services. So this is a program that's funded by UNITAID and World Hepatitis Alliance, along with PATH and the International Council for Women, the East Africa chapter based in Uganda, are leading this work in 16 or 17 countries, each with different levels of support. So we're very excited for that work to start, and it was just launched in Kampala on Monday. So we're very excited about that. But WHA also has other in-country programs looking at increasing testing. Our Find the Missing Millions program worked with members around the world to come up with advocacy strategies to advocate for better testing services in their countries. A lot of them were able to engage their ministries for the first time. A lot of them were able to secure additional funding. So that's one way that we kind of work on a more boots on the ground level to help our members increase testing within their communities. And we have other events throughout the year. We organized the World Hepatitis Summit, which will be in Bangkok, Thailand next April, which we offer a lot of support and a lot of learnings and experience sharing, case study sharing around diagnostics and effective testing programs, and especially community-led testing programs or community-based testing programs. And as I said, last year we started World Hepatitis Testing Week to give the hepatitis community or public health community in the world another touch point besides World Hepatitis Day in order to talk about hepatitis testing, to engage their governments around it, and hopefully to attract new funding and increase testing in different places around the world. And just finally, for this part, we know that stigma can play a huge role in people being hesitant to come forward for testing and to engage with healthcare generally. So the World Hepatitis Alliance has been doing a lot of work to try to measure the stigma that's being experienced by people live with viral hepatitis. We've done several reports over the years, and this year we just launched the first data from our Hepatitis Stigma Watch, which is a measurement tool around hepatitis stigma for both B and C, which we piloted in 8 countries in Europe in partnership with the European CDC. And the first data was published just a few months ago. And it definitely demonstrated that people living with hepatitis have experienced stigma within healthcare settings, within society, and within families. And really, if we want to increase screening and really reach our elimination goals, we have to address stigma as well as just merely clinical pathways, etc. And of course, as we mentioned before, it's World Hepatitis Day on Monday. Let's break it down as the theme. But I think maybe I'm just going to pause there, and then I think we're coming back to some of the calls to action, the way that you guys can get involved in World Hepatitis Day at the end, I believe. Is that correct, Chair?
Great, James, there, and thank you for that very informative highlights. And generally, we really need to know that the infection is going, hepatitis generally is going in the wrong direction. Very high infection acquisition, but low case identification, if I can call it that, and also very low treatment rates. And that's to me a triple tragedy, generally speaking. And so we need to act and act now to reverse some of these untoward trends that we're seeing with hepatitis, including but not limited to some of the things that have been highlighted here: service integration and making sure that we identify as many of the cases. So colleagues, keep your questions coming related to the first session, and now we're moving to our second speaker. And our second speaker, like I earlier indicated, is going to be Dr. Linda. And Dr. Linda, over to you.
Thank you. I'm going to be speaking about a study we did in Uganda to look at the affordability.
Dr. Linda, confirm that you can hear me. Great.
Yes, I can hear you. Can't you hear me? Hello? I can hear you.
We can hear you, Doctor.
Great, kindly continue. Please continue. Thank you.
Okay. So I'm going to be speaking about a study we did to look at affordability of hepatitis B viral load testing in antenatal setting compared to the standard of care, which we are all used to. Okay, just a moment. Let me try. Okay. And just to declare that this presentation is being made on behalf of CFAID. We did a study in Uganda to describe the operational characteristics and ease of use of assays and the cost of using GeneXpert machines for hepatitis B viral load testing in comparison to the centralized conventional testing. Just to say that presently, all viral load testing in Uganda for hepatitis B is done on centralized platforms using plasma. And this causes a big challenge, especially for pregnant women who have a time-limited, intervention time. So this is the outline of my presentation. So just a little background, Uganda still has a high hepatitis B burden with a significant risk of vertical transmission from mothers to children. As you can see, our overall hepatitis prevalence is about 4.3 and 1.4 in pregnant women, and in children less than 5, about 0.96, and in children 0 to 14, about 0.6, with an annual birth cohort of about 2.2. It varies, in the different regions, and where you can see the darker green is where we have the highest rate of hepatitis B infection. And we see that we have higher hepatitis B in people who have HIV at about 4.7. And this is our program performance for the PMTCT program specifically. The first graphs are showing a comparison of HIV testing, syphilis testing, and hepatitis B testing for antenatal women. And as you can see, HIV has constantly been above 95, almost 100%. Syphilis was at 86 in 2020 and has hit 95%. But hepatitis B is really still lagging behind, but improving from 12% in 2020 when we had just rolled out the triple elimination to 58% where we are. And the second graph is talking about treatment. You can see maternal ART coverage is above 100. Syphilis treatment has hit the 90% target, but hepatitis B treatment for pregnant women is also still really lagging behind at only 46%. So this study was timely. We wanted to verify the diagnostic accuracy of the CFED expert hepatitis B viral load platform with what we are using at the moment, the Roche platform. And we had two phases of the study. The first one was to verify the diagnostic accuracy. And the second phase, which is the most important for this presentation, was to describe the operational characteristics, ease of use of the assays, and suitability for their scale-up in Uganda, and also to look at the estimated cost of utilizing the GeneXpert as compared to what we are using at the moment. So the phase 1 was actually done in the lab, and it just proved what we all thought it would be, that it was in perfect, that GeneXpert was in perfect agreement with the reference test, with sensitivity and specificity of 100% and a very strong correlation. So for the second part of the study, we recruited 259 pregnant women. Actually, those are the ones we screened, although found that some of them were not eligible, either because they were already on treatment, either for hepatitis alone or for co-infection. So in the end, we had 181 who had GeneXpert done on the platform. And we looked at various clinical assessment parameters, and of those we managed to match 123. So the results for the lab assessment, we'll be talking about 181 women, but for the matched is that number 128. So in phase 2, we strictly looked at pregnant women, 24 weeks of amenorrhea, and only those who provided informed consent. And for those who did not provide informed consent, we went ahead and enrolled them in the conventional care for hepatitis B PMTCT. We conducted this study in 10 high-volume hospitals and worked with the actual health workers in those hospitals, the midwives that are doing antenatal care, and the laboratory personnel who are, working in those facilities to do the work. And we made sure that for all the women, who are in this study, we ensured that they went through the triple elimination. They had HIV and syphilis screening, and for those that had a positive, hepatitis viral load above 200,000, we ensured that we linked them to care. Just to speak a little about the women, the biggest number were between 15 to 24 years of age, and mostly gravida 1 or 2. And many of them were captured either at antenatal 1, 2, or 3. So speaking about the turnaround time using the GeneXpert at the sites, we saw that it generally improved all aspects of the turnaround time. 96.7% of the samples were dispatched from the lab to the lab on the same day, and 99% of results were actually processed on the same day, although we saw some delays in the results getting back to the clinical, the clinical people, with about only 77% of results getting back to antenatal care health workers immediately, and only 61% of mothers are receiving their results on the same day. We had quite a number of mothers who said they couldn't wait because the GeneXpert being a multiplexed platform, sometimes there are many other samples that have to be, processed. So some mothers couldn't wait until the results are ready, so they came back within 1 or 2 days to pick their results. But generally, we had over 88% of mothers getting results within 2 days. We saw a bit of delays in result transmission from the lab to the provider, and also from the provider to the mother, as I said, majorly because of the multiplexing issues and the fact that others also have to other samples also had to be worked on. So looking at the outcomes, 87% of patients had a low or undetectable viral load. 18% had undetectable viral loads, while 69% had viral loads of about 20,000. We had 2% that had viral load copies between 20,000 and 200,000, and 12% who had viral load copies above 200,000, who needed, management according to the Uganda guidelines. I have to say that Uganda guidelines have not yet fully adopted the new WHO guidance. We have gone through the process, but we are at the final stages of having the approvals done. So we still manage our PMTCT of hepatitis according to the old WHO guidelines, where we give prophylaxis at 200,000 copies and above. So for linkage to care, of the 22 mothers that we've seen that were eligible for prophylaxis, we managed to start 14 of them on TDF immediately. Out of those 15, out of the 22, 15 we were able to trace that they had delivered their babies in our health facility. And out of the 15 that were delivered, 11 had their babies vaccinated. However, of the 14 that we managed to initiate on prophylaxis, I have to say we were not very happy about the loss that happened between the 22 and 14. But I think those are systems that we still have to work on within the country, and I'm sure we face similar system challenges everywhere. And of the 14 that were started on prophylaxis, 12 were still in care at the end of the study, and we were able to trace them fully. One mother had all the three. She was positive for HIV, syphilis, and hepatitis B. We were, however, not able to trace the mother because she had been referred from a lower facility. The health workers really said point of care testing made it very easy for them to manage the eligible mothers because they got the results early and were able to start the mothers on prophylaxis immediately. and that it also helped in clinical management because sometimes you're not so sure where the mother stands. But when you do the viral load, then it's easy for you to know whether they're eligible for prophylaxis or they actually need to be on actual treatment and not prophylaxis, or they need to wait. So viral load is still very critical, even when we, as countries, go to do test and treat, because it will help us to understand where our mothers started from, so that we can be able to do proper monitoring. When we looked at the costing issues of POC versus conventional, we costed each parameter for us to come out with the final cost. We saw that the GeneXpert platform was about, or in total, costed about $15.37, which is very comparable with the conventional that was at about $15.26. For the conventional, we costed the cost per sample, and it came to about $2 for each sample to be moved from the peripheral site to the central lab. However, we have to say that this cost does not really take into consideration the costs to the patient, them having to return several times to the lab, to the facility for results. I am sure if we added all those, then probably the conventional would actually go, much higher. But also we think that at the time there were only few people, a few of us that are using the POC, and therefore it is still quite expensive. And that if we have issues of economies of scale and many people are using it to a large extent, then we would be able to bring down that cost to an even more manageable amount. The healthcare providers highlighted a lot of positive, experiences and benefits for the GeneXpert platform. And most of them said that it was easy to operate and it required minimal training. A few said that they really managed to do an integrated, managed to integrate their services and balance the testing for hepatitis B together with all the other samples that they had to do on the expert platform, including TB, HIV, and COVID-19. And of course, as we've already seen, it really quickens the turnaround time. And also, the patients were really satisfied about the fact that they are able to get their results in a timely manner and have the best possible management given to them. These are some of the provider experiences. I will not read all of them. They said the machine was very easy to use and turnaround time is within time. Some of them told us before it was really challenging. You have a mother, you do have, a hepatitis B surface antigen. You tell her it's positive, but you need to take off a sample for viral load before you do any management. And then the result would come back between 2 to 3 months. And, all that time, you're trying to allay the fears of the mother. And it is very difficult. And for most of them, because they run integrated HIV and hepatitis B clinics, it was very easy to streamline the care and linkage for the patients. And it was reported that the mothers really appreciated getting their results on the same day and not having to wait for a long time before a decision could be made. Of course, there were a few issues. In the beginning, there were some cartridge rejections, which we improved with training. Then there were some system configuration issues, which we also were able to troubleshoot immediately. And of course, the usual stakeout of hepatitis B test kits, which delayed our recruitment of patients. And then earlier at the beginning, they also had issues with interpretation of the viral load results because they came as log values, which sometimes was a bit hard for them. And of course, the major one was the multiplexed platform. They have so many samples that are waiting to be processed, and they need to make sure that all of them get processed, and every clinician feels their sample is equally important. And for that reason, we saw some of the delays with some of the mothers getting their results within 2 days. So in conclusion, the positive attitudes of the antenatal care teams enabled successful integration of services, linking the hepatitis B positive mothers to care. The issue of the fact that their patients are going to get care within allocated time really motivated the healthcare workers, and therefore made them work even better. We saw a lot of team integration between the clinical and laboratory team, and then integration of hepatitis clinics within facilitated comprehensive care for the pregnant women, and where hepatitis B services were collocated within MCH, we saw that the mothers were able to get their care in a very streamlined manner. We also realized that it's still very important to work with the community, because as you see, we lost quite a number of mothers who went back to the lower level facility. And it's also important to continue screening the mothers to, even as they can come back for other follow-up antenatal visits, because we saw that some of them sometimes missed screening on antenatal 1, but when you ask on the follow-up antenatal visits, you're able to catch those that were not tested in the first antenatal, and you are able to test them. Then we need dedicated follow-up efforts for hepatitis B patients so that we can link them to care. We were really, very unhappy about the number of mothers that we lost, that were not able to get prophylaxis even when they needed it. But most importantly, we saw that the costs of conventional and POC are very comparable. But when this is taken in the context of mothers being linked to care and treatment immediately, and avoidance of having to return for results, it means that POC is ultimately more cost effective. So we hope that when we plan to roll out, we'll have many other people coming on board, and we'll be able to take advantage of economies of scale and as we roll out. Thank you very much. That's what I had to share from Uganda. Over back to you.
Thank you very much, Dr. Linda. And Lucy, just keep in the background and be sure that my connectivity is not as bad. It is storming in my area and it compromises my connectivity. So thank you again very much, Linda, and what a sharing, because the comparative study for the conventional versus the gene expert that is widely available out there, and of course the results, perfect prediction, because your correlation coefficient of about 0.99 is really perfect prediction using either of the two platforms. But also this perfect prediction because you're doing it at near point of care, because gene expert devices are kind of more or less near point of care devices. And so this then helps us scale up services to improve access while maintaining quality, and quality in terms of time to result success by the recipients of care, our clients, or the care providers, the healthcare workers who need this information to make their next decision in the management plan of these patients. But also improving access while holding test validity at the space where it should be. So what a sharing from Uganda there. So let's now get to some of the questions that are coming through. And colleagues, please let your questions keep coming through the chat. And it is in the Q&A space, and then we'll be dealing with them. Linda, let me start with you. There is a question. I know that the costing that was done was cost per test, and you alluded to the fact that you did not do the cost related to our recipients of care, the clients, and that would still probably pull down the cost for the near point of care testing platforms. But there is a question that is coming in directly to me, and it is an intriguing one, and you can't defer the answering, but it relates to the cost per test only looks at how much the test is going to cost us. But if you looked at it from the perspective of for you to do near point of care testing, you need to deploy 100 devices. And as opposed to one device that might be centralized. And so the cost per test, if it does not factor in the fact that you will then need to deploy 100 devices and then also have about 100 trained operators dealing with those devices. So that aspect of costing, somebody is here asking whether it would probably change the current conclusion that we're making out of this, that the near point of care is cheaper or really comparable to the centralized testing. Your opinion on this, because I know you've not done it, but what would you think might be the play with that factor in your costing?
I think there are a lot of issues to consider there. First of all, remembering that the GeneXpert platform is a multiplex platform. So when you deploy 100 of them, you are going to make viral load for HIV easier, viral load for hepatitis B easier, TB testing easier, COVID-19 testing easier. So, HPV testing easier. So you are bouncing off so many tests that are going to, very many different patients of many different calibers are going to benefit from these 100 devices. So it's not only the hepatitis B patient. So when you look at it in that, in that context, and then I know that most of us with the centralized testing, we have been majorly depending on the sample transport network with the hub riders, with motorbikes, with maybe some cars. So when you bounce off all that, and especially now when we are having these challenges of funding, then I don't know, the cost of the machine one-off is quite costly, but you know that you're going to continue using it for many years for many patients. So maybe that's another study that someone can think about. And I know that cost-effective studies are very, very challenging because so many small pieces that sometimes are very easy to be put together and make someone understand. But I think we need to think about it in that context, that you deploy the machine once and it's going to help very many patients of different categories. Over.
Thank you, Linda. And let me hold it with you one more time before I get to James. And there is a question that is coming in from an anonymous attendee, and it says, do the centers that are doing this testing have mechanisms to incorporate the test results into their medical record system to ensure that these are captured appropriately in the medical record system to reduce the additional cost associated with multiple testing on there is a problem here on some of the poor record keeping platforms that may be out there?
So I think I forgot to say that we worked with the CFAID team to make sure that the LabXpert platform was capturing the hepatitis B results similar to all the other results that they are already capturing. And this is linked directly into our lab lab information systems. So the results were going directly into the LIMS. And so there was no need to come back and then record here and record there. So we worked very closely with the CFAID team. And if they are here, I think they can also say something about that. It was very, very helpful.
Thank you. Thank you very much, Linda. And we'll get to the CFID team. Fitsam, just be on the lookout for colleagues that may have tagged CFID to their names and upgrade their status on the platform. James, let me get to you on two issues. The first is the upcoming World Hepatitis Day is looking at really dismantling the barriers, and the barriers are financial, others are social, and others are systemic. Do you want to speak to some of the systemic barriers that we seem to be seeing overly affecting either the diagnosis or the monitoring or the initiation of treatment on people that are exposed and may have hepatitis B or C?
Sure. I mean, hepatitis has been, unfortunately, it's kind of fallen through the cracks of what has been, the global health response in the last 20 years. And I think because of, historically, the kind of focus on HIV, TB, and malaria also led countries to look at to those as the three most important issues that they should be addressing domestically. And a lot of times hepatitis has been left out of that conversation. And because it wasn't also discussed by these global donor organizations and things, it's sort of a self-perpetuating problem. And then when you look at the diagnosis rates, 4%, you have very few people living with hepatitis B that are going to speak up for themselves and demand from their policymakers that more needs to be done. And then when you consider the high levels of stigma that exist everywhere, then you're limiting the number of people who are willing to be visible, to be advocates, to be pressuring their governments in order to, to make things happen. So I think hepatitis has been too easily ignored. I think the fact that people don't die of hepatitis, they die from cirrhosis or liver cancer. And again, that link to liver cancer is not well understood or articulated within health systems. So the deaths from hepatitis aren't necessarily that evident. And the fact that even children that acquire hepatitis at birth, they won't start showing signs of cirrhosis or infection until they may be in their 30s or in their 40s, although that age is getting younger. So there's also a disconnect in between the need for PMTCT and actually when those people are going to be needing that extra care. So I think structurally there's a few things around hepatitis that really have been kind of holding us back. And luckily, I mean, at least in Africa, in a way, HIV treatments up until today have included tenofovir, which is the primary treatment for hepatitis B. So actually, if you are living with HIV and you're also living with hepatitis, you have been getting your hepatitis B treatment, even if you haven't been diagnosed, even if you weren't diagnosed. But now with the onset of dual therapies that don't include TDF or the long-acting injectables, which also don't include TDF, there's a huge issue about getting these people who are living with HIV tested for hepatitis B, and then what do we do with them if they change their treatment? So I think there's lots of structural things that need to be addressed. But I think the examination of how donor programs interact with government programs and governments really looking at having a more holistic approach to their health systems and less of a siloed or disease-based approach. I think there's opportunities for hepatitis to kind of emerge and to be addressed in a really cost-effective and a holistic way. Thank you.
Thank you. Thank you very much, James, for that comprehensive response. Let me keep it with you and just deal with again one more question, and it is also again a very general one. And so this speaks to the triple elimination strategy. And we know that HIV, syphilis, and then hepatitis, that's the drive. And you've just spoken to the fact that hepatitis may actually drop through the cracks. So, in your opinion, do you feel that most of the controls have been put in place so that when we implement the triple elimination strategy, we do not run a risk of losing on any one of these three diseases? The dominant HIV might overshadow the hepatitis initiative. So, do you feel that some of the drives that have been put in there and controls are making sure that none of the three is either taking a lead or remaining behind?
So good question. I mean, I think a lot of the triple elimination strategy is building on what has been done in HIV, PMTCT already. And we know that prevention of mother-child transmission programs for HIV have been very successful in Africa. So it's really building on that infrastructure in order to also include syphilis and then hepatitis. So I think inevitably there's more HIV PMTCT programs than syphilis that include syphilis or that include hepatitis. So there's going to be alignment where the two PMTCT programs are already existing to come into one strategy. And I think inevitably, yeah, we're going to be building on existing programs that might have been built for HIV. But the we often say small steps by these programs can have a big difference. And it's only a small step to also screen the woman for HPV, to provide prophylactic treatment. And it's really the birth dose is extremely important, because even if the woman has undiagnosed hepatitis B, even if she hasn't had prophylaxis during pregnancy, the birth dose is still highly effective in preventing transmission of hepatitis B, up to over 90% effective. So I mean, making sure the birth dose is part of it, and that is a new thing that hasn't been in PMTCT programs as well, because it has to be given within 24 hours of birth. It's the only vaccination that has to be done in that time frame. It's very important that it is done so soon. So really, that's going to be it. That's the challenge that I think a lot of these triple elimination programs will have in implementation. But again, there's support from Gavi in those countries that are already receiving vaccination support from Gavi that can help make that transition and to really have those things put into place. Thanks.
Thank you. Thank you very much. Linda, let me get back to you with a question or two. And I think there is one that is coming in from Godfrey, and I'll try and summarize it. So Godfrey is asking, and I think it is drawn from the fact that you did your literature review when you were doing the study, and so probably you came across other test platforms for hepatitis viral load, and maybe the costs therein could have been cheaper. So could you have landed on some other platforms other than the two that you are comparing that seemingly are providing cheaper cost per test, but also what is their deployment approach? Are they decentralized deployment or centralized deployment, if you came across any? And again, we'll then get to our industry partners, if CFID is here or any other, and they could speak to the fact that if there are other platforms and if they know the cost per test. But from your literature review, were there some other platforms that you came across other than the two that you've compared here?
I have to say that I think we came with a sort of a biased view. So we didn't really look around much, but also we didn't find much information on hepatitis B point of care testing. So we, just approached it from, let us try and do this and compare the two and be able to provide information. But I know there are quite a number of studies, I think, from the Gambia that were, that have, looked at issues of point of care. And if any of them is here, maybe they could give us some information.
Great. And then we have an interesting question, and again to you, Linda, on the children that we are vaccinating against hepatitis B. Are we confirming whether they're immunized or not, or we have not reached that stage? And if yes, what proportion of those that we are vaccinating are getting immunized?
That's a big question that we have been asking ourselves in the country. Are we really sure that, this immunity has caught and, we are dealing with people who are covered? We have not yet answered the question, but I know that our Virus Institute is doing a study, and we are looking really forward to them giving us that information. It's been a question that comes up again and again. Even in our study, we were asking about the mothers less than 24 years who got the pentavalent. And we found that even some of the mothers who are Hep B positive had either had one dose, or some had 3. So I think it's one of the questions at the end of the study that we actually put down that need to be responded to. Over.
Great. Thank you. Thank you very much. And I know there is a participant who is asking if I've seen the question. Kindly repost it. We have barely 2 minutes to close. And for those that are asking for certificates, yes, you will receive an email from our communications team. The email address that you used during your registration, you'll get an email with guidance on how you can get your certificate. So just follow the guide there and you'll be able to get your certificates. And I'm still looking up that question, and I have seen also a question either in Portuguese or French that we will see if we can answer it. But as we wind up, let me start with James, Cary James. And I know we struggled with the spellings of your name at some point. Our apologies. Kindly give us your closing remarks as we head to Monday, the World Hepatitis Day. Your closing remarks. Yes.
So like we said before, let's break it down is the theme for this year. So let's break down the barriers that are holding us back from hepatitis diagnosis and treatment. If you want to check out the website, worldhepatitisday.org, it's filled with resources that everyone can use. They're totally open source. You can download them for your own social media feeds. We've done a series of videos with doctors and key opinion leaders around very popular questions and misconceptions and myths about hepatitis that we answer. And you can download those videos and use them yourselves if they're applicable. So there's loads of things that we can all use on there. We do a relay every year where people create video content and then post it on their social medias at midday in their time zone. And we kind of go all around the world. So if you're interested in doing that, you can please email us and we can post that for you. And we have 2 more webinars coming up. Tomorrow we have our community forum, which are people living with hepatitis from around the world, and they'll be sharing their perspectives on stigma and discrimination this year. And then on Monday is the World Health Organization global webinar for World Hepatitis Day, which is co-hosted by us and by Rotary International. And again, it's a really great international lineup. So please think about joining that on Monday. And just if you want to know more about Hepatitis Testing Week, it's heptestweek.org. And our Medical Visionaries program is our medical professionals. It's like a champions program. It's open to lab technicians, doctors, nurses, all medical professionals. So you can check that out at nohep.org. And that's it. Thank you so much.
Thank you. Thank you very much, James. And let me hand it over to, we have barely 30 seconds, but Linda, as you do your wrap up, kindly also try to address this question. And Lucy is asking what the viral load was for the positive hepatitis test in your study. So your enrollment criteria for those that you were then doing the samples that you were doing comparison with, as you do your closing remarks. Linda, over to you.
Okay, thank you. I've not really understood the question, but I am thinking that there were think they were asking at what point were we starting prophylaxis? I don't know. We were starting prophylaxis at 200,000 and above. And maybe just to the few remarks is that you know, the hepatitis, you know, we saw how much we improved syphilis on the PMTCT platform when we worked and added syphilis together with HIV. And, you know, the getting of the dual test kit really made a big difference to the syphilis programming. And hopefully, yesterday at the last 3 days at the triple elimination conference, 2 triple kits were introduced, one of which has already been WHO pre-qualified. And we are thinking that these will really be a game changer for the triple elimination. And I think lots more, you know, innovations are still needed to make sure that we implement the 3, you know, on the maternal and child health platform. But also just to remind everyone that in this era of limited resources, integration is very key. Use that one platform, manage so many things. So maternal and child health platform, 3 infectious diseases, even more. We can add TB, malaria to that. Same health worker, same infrastructure, and then we will be able to have a healthy population. Thank you very much, and over.
Excellent there. And we have 2 questions that we'll share with Linda and James. And when we get the answers, we'll make those available to you as we're sharing the other resources. Excellent sharing for today, for sure. And let's all work to dismantle the barriers to hepatitis elimination. And colleagues, with those, we've come to the end of today's session. For those that may want to share with us on this platform, I know that question was also available. So if you have some work that you've done and you want to share with us, kindly reply to the mail that is being sent to you for your certificate access, and then we'll take it on from there. You can also alternatively reach out to me at FOCEN@aslm.org, FOCEN@aslm.org, and we'll take it on from there. Thank you very much again, and do have the best of your afternoon, evening, or morning, depending on where you're joining us from.